Now coming to the clinical presentation. Onset of symptom happens immediately after injection. As I said earlier, most of the time it is less than 1 minute. The prodromal phase includes dysarthria, perioral numbness, confusion, patient might have dizziness, seizure and coma. Cardiovascular collapse, there is going to be hemodynamic instability and patient will have cardiac arrest. Coming to signs and symptoms, isolated CNS symptoms can be seen in 45% of the patient, but cardiovascular it is slightly less, it is around 10 to 11%. And combined cardiovascular and neurovascular system can happen in 44% of the patient. In the CNS, there can be a prodromal phase of dysarthria, tetanus, perioral numbness, confusion, agitation and dizziness. As the symptom progress into severe symptom, there can be seizure and coma. With regard to cardiovascular system, early can be hypertension and tachycardia, and in the late cardiovascular system, you might have hypotension and dangerous arrhythmias, but the usual presentation can be bradycardia, tachycardia, pulseless electric activity, finally end up in cardiac arrest. Coming to CNS toxicity, it is the most important component of the last and it is the initial feature. It comprises of many initial prodromal features as I mentioned earlier, but often manifest only as seizure. Here most important theory is around what is called the task, which is twig related acid sensitive potassium channel. This pH sensitive channel generates neuronal potassium leak currents and are expressed throughout the brain. Through this channel only the seizure happens. Local anesthetic inhibition causes membrane depolarization and increases neuronal excitability resulting in seizure. Coming to cardiac toxicity, this is the next important component of local anesthetic systemic toxicity. It is mostly related to accidental intravascular injection. Here, it binds and inhibits voltage gated sodium channel. With regard to neuronal, it is potassium channel. Here, it is voltage gated sodium channel and it presents as conduction disturbances, contractile dysfunction and ventricular arrhythmias. With regard to bupivacaine, the cardiac toxicity has a higher incidence with bupivacaine when compared to lignocaine. Bupivacaine avidly blocks inactive sodium channels during cardiac action potential at 0.2 microgram per ml concentration. Even at low dose, it can block the sodium channel and it acts by what is called fast in and slow out. By greater uptake, it goes and binds with the sodium channel very rapidly, and as the binding is very strong, it comes out very slow. So, it goes in fast but comes out very slow. So, it is going to cause more toxicity when compared to lignocaine. And coming to lidocaine at 5 to 10 microgram per ml can result in substantial sodium channel blockade during cardiac action potential. Here, in contrast to bupivacaine, it is going to be fast in and fast out. There is greater uptake, so it goes in fast, but the weak binding makes the dissociation also very fast. So, it goes in fast and come out fast, unlike bupivacaine. There is going to be quicker recovery and reduced incidence when compared to bupivacaine. Cardiac changes is often after CNS toxicity. More potent local anesthetic can lead to cardiac toxicity first. Okay, here when you give more potent local anesthetic like bupivacaine, cardiac toxicity may precede or happen concurrently with the seizure. Hypotension and bradycardia are often the sign of cardiac toxicity followed by arrhythmias, and here there is going to be bradyarrhythmias rather than tachyarrhythmias. Additional signs of cardiac toxicity includes hypertension, dyspnea, pain, weight complex, ST segment changes, asystole, tachycardia and ventricular tachycardia and fibrillation.